multiple national and international position in professional societies. He comes from the institution with a proud of history of many decades of innovation and leadership in intervention endoscopy, as well as institution which provides training and education and sharing worldwide experience and skills throughout all those decades. Professor Teoh himself has been a crucial innovator and key opinion leader since the very beginning of new era in interventional endoscopic ultrasound, and he's also a lead investigator of many published studies, including crucial randomized controlled trials on Lumen Apposing metal stents and application of this technology. He's not only our frequent collaborator, but most importantly, also dear friend and inspiration in our work. And thus, without further ado, and with excitement about hearing his lecture, please allow me to hand over to Professor Anthony Teoh.
Thank you, Rasti, for your very, very kind introduction. So I'm very happy to be here, although virtually, to share my initial experience with the novel endoscopist deploying cautery enhanced lamps, the Z-EUS IT system. These are my disclosures. So before, our life was so simple, right? Because we don't have so many stents to choose from. But since the birth of all these new EUS devices, life is becoming more and more complicated. And if you look at the family of EUS-specific stents, there is just so many for you to choose from. And in fact, all of these stents serve a particular purpose. Of course, there are many design considerations for a stent. The way the stent is being deployed, the material, the covering, cutting, any anti-migration properties, these are all design considerations, and also really depends on what kind of procedures that we are doing the EUS intervention for. Clinical considerations, of course, there are many type of procedure, indication, benign versus malignant, stent patency, and also the risk of stent migration. So these are very important considerations when designing a stent. And we know in the recent few years, there's the emergence of this very important category of devices. That is a single-step device. So in the past, EUS guided interventions require usually several steps, puncturing the target, followed by passage of the guide wire, followed by tract dilatation, and also stent deployment. And nowadays, we can combine all these steps with a cautery enhanced delivery system. So in the past, only Axios is available. Now also Spexis has become available. And later on, I will introduce another brand name that is providing these new devices. The other thing that is very interesting is the way the stents are being deployed. We are very used to all these assistant controlled deployment systems. So very similar to ERCP or esophageal or gastric or duodenal stents. We require our nurse or our assistant to deploy the stent. But with Axios, they have made a really big turnaround in terms of deployment is the endoscopist controlled system. So with the endoscopist controlled system, there are a few advantages. We can be very precise, especially in very tight area of small organs. You can do the entire procedure by yourself. So for example, you're in a unusual environment or in the ICU where no one is used to assisting you. You can do everything by yourself. But of course, these deployment system needs training and may potentially be more expensive. And all these specific EUS-specific devices has allowed us to perform many, many novel procedures. And we have seen in the past few years a exponential growth in the number of EUS-guided procedures. And also these EUS-specific devices may reduce the risk of leak and adverse events, shorten procedural time, and most importantly, make the procedures a lot easier. So nowadays, we can do drainages basically in any organ that is close to the GI tract. The GJ, gallbladder, CDS, HGS, basically everywhere we can drain it. So I would like to introduce this new system from M.I.Tech, the Z-EUS IT system. The specific characteristic of this system is that It is a cautery enhanced device. It is the endoscopist controlled delivery system. This is a lure lock, which allows the device to be attached to the echoendoscope. And then there's this lock, which allows us to advance the delivery system and puncturing the organ. After puncturing the organ, this gray rotating knob allows us to rotate 180 degrees and allows us to deploy the distal flange, followed by approximation of the flange to the lumen. And we rotate this knob another 180 degrees to deploy the remaining of the stent system. So this is the lure lock. This is the cautery attachment. So as we advance this tip, we click on this knob, and then we advance the delivery system so as to puncture the organ. Once punctured into the organ, we lock the system again. We rotate this handle, and then we push the handle backwards to open the stent. And then we approximate the stent by retracting the handle. We rotate again the knob to open the proximal flange. So this is a video which tells you
before placement
how the system opens like that. You advance
sheath handle is to advance
handle.
the delivery system into the unintentional deployment of the stent.
And then you rotate this.
To unlock the stent deployment spin lock, rotate 180 degrees in any direction.
This is the spin lock.
To deploy the distal flange, rotate the spin lock 180 degrees. The first deployment is ready when you see odd numbers of deployment indicators.
And you open this
To
system.
deploy the proximal flange.
And to deploy the
second
flange,
deployment is ready when you see even numbers of deployment indicators.
And you open it. So in terms of the stent itself, it's a plumber stent, which is produced by M.I.Technology. I would consider it as a lumen opposing stent because it has been shown to have a high lumen opposing force, and also the flanges of both ends of the stent would prevent migration. So you can see the lumen opposing force of the stent compares very well with other brand names. So let's see this in action. This is a patient with an elderly patient with acute cholecystitis, and we performed U.S. guided gallbladder drainage. So this is the system, as we've seen. So I'm not sure if okay. So by advancing the delivery system, we could puncture the gallbladder. So we puncture directly with the system. And then we inserted a guide wire because it was still early in our experience. So we just wanted to be safe. And then we rotate. And then we open the distal flange. And you can see under US guidance, the stent is opening slowly. And when the stent is opened, again, we would approximate the lumen by pulling back the stent. And then we rotate 180 degrees, open the remaining of the stent. And this is inside the channel of the echoendoscope. And then we push out the stent as per usual. So this stent is a little bit longer. It's a 3 centimeter stent, but it does come in different sizes, like 2 centimeters. And also it comes with several different diameters, from 8, 10, 16, and so on. So this is the gallbladder drainage. And afterwards, we see very nice material being drained out from the gallbladder. This is the opening of stent. Another case of a ward of necrosis. This ward of necrosis is at an unusual location. It is at the D2-3 area. So my scope was at an angulated direction. So this is the collection. So because of this unusual location, I punctured with a needle first, followed by insertion of a guide wire. There's some contrast in there. And then I changed to the Lumen opposing stent again. Right there. And then I burn my way in. Again, following opening of the stent with this device. I'm not gonna repeat too much because of time. And then we open the stent. You see the stent opening. And then we pull back a little bit, as per usual, open the remaining of the stent within the echo endoscope channel. And then we push out the stent. So this is at the, you can see the position is unusual. This is in the D2-3 area. You can see the scope position after deployment. Okay, one final case. It's a complicated case. This is a patient who had a Mirisis syndrome and then cholecystectomy complicated by bowel duct injury with a hepatoduodenostomy. The patient came back with an XJ stricture. So we had difficulty trying to access the XJ stricture. We did a double balloon and we couldn't reach it. So at the end, we decided to do a stenting from the duodenum to the rulim so that we can use the stent to get to the XJ. So this was a US guided AFib limb drainage procedure, and it was shown in the US guideline last week. So you can see the small bar right there. So my scope was in the D1 area. After puncturing, I infused saline into the XJ. Afterwards, when I felt that it was distended enough, I passed a guide wire, and then I used the guide wire to guide my Z-EUS stent to be inserted into the XJ. And then afterwards, I opened the stent under X-ray and US guidance. You can see the stent opening very well, followed by deployment of the proximal flange. Okay, after deployment, you can see the stent position is quite nice. And this is the opening. And then a few days later, I used the stent to insert a gastroscope to enter into the ruling. And you can see the stent I placed was at 60 millimeters and allowed the passage of my scope, and the XJ was very small right there. And finally, I was able to pass a guide wire into the XJ, followed by dilatation. And then finally, 2 plastic stents were placed to dilate the XJ further. So as you can see, between December 2021 till now, this is not July's till now, so we had some experiences. This is not all my patients. It included Rasti, Pires, Miranda. We did this as a group, so it's just not only me. several gallbladders, several PFCs, and one complicated exchange drainage. Technical success was 100%. And I think the stent worked very well in terms of simple procedures as well as complicated ones. So in conclusion, performance of U.S. guided drainage with the novel endoscopist controlled cautery enhanced lamps was safe and effective. And the plumber stent could be used for all sorts of procedures, including PFC, gallbladder drainage, and even gastroenterostomy. So thank you very much for your attention.
Thank you, Anthony, for excellent presentation and overview on this novel device, as well as what we have available in our portfolio right now. I have a few questions. I'm definitely strong believer about endoscopist control, Lumen Apposing metal stents or devices for their deployment, especially in more complex or technically demanding procedures where we prefer to use freestyling techniques without guide wire, without needle. Yeah. Do you find yourself any of Z-EUS features or characteristics distinctive from the other known Lumen Apposing metal stents? As well as how do you see, for example, learning curve? As you mentioned, we have some experience, but do you see that learning curve might be different from other devices which are also operator controlled?
Well, definitely, because I think you know, we are the older generation, so we have learned things the hard way. We didn't have devices, but by training younger endoscopists, they are so used to all these endoscopist controlled devices, Lumen Apposing stents. When I asked them to do things the old way, they really found it to be very difficult. And a lot of times they were surprised how difficult it was in the past. So I think in terms of learning curve, it really makes life easier, and I think probably safer, because by having a cautery enhanced single step device, you really do not need to change devices all the time, and it saves procedure time as well, and it prevents mishaps from happening. For the plumber stent, I'm quite happy with it, because when we do all these freely mobile organs like gallbladder or the small bowel, if you don't have a strong stent, I think there's always a risk of stent migration, and it would be catastrophic if it happens. So at first, I'm not 100% confident with the plumber, but I think with more experiences, I think even with the final case of the complicated exchange drainage, I think it really showed me that it was provided a very strong Lumen Apposing stent and was able to oppose the jejunum to the duodenum as well.
I think it was very exciting to see when you showed the Lumen Apposing force particularly for this stent, where it stands in comparison to other stents. Yeah. Emily, do we have any questions from the audience?
Any questions here? Miro, Stephanie, any questions? We do not have questions, so I have one. As you know, we will provide more samples with the final upgraded version during end of November and December. Do you have any plan to try this with another indication, the unique indication?
I think we are trying with all indications, right, Rusty?
Yeah, I think that we do not limit ourselves into any standard indications, despite that we also need to honor, you know, obligatory, you know, contractual commitments which we have towards these novel devices. But certainly our mission is also to broaden the indication spectra in these cases. So I do not see any major difference why we shouldn't apply this in all these variety of indications, as Professor Teoh already shown, which is indeed excellent case, and it's becoming more and more daily routine, especially in hepatopancreatobiliary centers, surgeries. That's how we are now dealing with these adverse events or complications or sequelae of different styles of biliary surgeries.
Yeah, I look forward to explore all the other indications with our new device very soon. Thank you for your great the lecture today, Anthony, and thank you for your moderating, Rusty. Hope to see you very soon.
Thank you. Thank
Thank
you.
Very much. Bye-bye.